So good morning everyone and welcome to this session. Today we are going to see about the cubital fossa and the forearm muscles. Okay, the muscles in the forearm. Okay, cubital fossa. So what is this? The cubital fossa, it's actually a misnomer. It needs to be in a cube shape, right? But it's actually not a cube shaped one. It's a triangular depression present near the elbow. Okay, a triangular space which is located near the elbow. Okay, and it is bounded by certain muscles which we are going to see now. Okay, and an imaginary line. Okay, what is the importance of this? We will see during the course. The boundaries, it is bound medially by this muscle. Here you can see a muscle which is arising from the medial epicondyle. Okay, so what is this name of this muscle? Are you able to see? Pronator teres. Okay, pronator teres. Okay, why this muscle is being named pronator teres? So as said earlier, most of the muscles, they are named either on their origin or insertion or on their actions or on the shape. Okay, pronator means it's an action, pronation. Okay, and teres, it's a round shaped one. Okay, so it's called as pronator teres. So medially it is bounded by the pronator teres, and laterally it is bounded by another muscle which is brachioradialis. Brachioradialis. Why this muscle is named as brachioradialis? Because it takes its origin from the arm. It takes its origin from arm. Another name for arm is brachia. And it goes and gets inserted until the radius bone. So that's why this is called as brachioradialis. So medially by the pronator teres and laterally by the brachioradialis. Okay. So laterally brachioradialis and medially by the pronator teres. And the base, it's by an imaginary line joining the epicondyles, medial and the lateral epicondyle of the humerus. Okay, the medial and lateral epicondyle of the humerus. Okay, the epicondyles are located above the condyles of the humerus. Okay, so these are the three structures. Okay, so the medially by the pronator teres, laterally by the brachioradialis, and the base is by an imaginary line joining the two epicondyles. The apex is present at the place where the brachioradialis and the pronator teres they cross over. Okay, so here you can see this is the apex. Okay, so this is a hollow triangular space present near the elbow. Okay, so this cubital fossa, it is somewhat similar to a room. Okay, so it has got a roof, a floor, okay, roof, floor. The lateral and medial parts we already seen, laterally by the brachioradialis and medially by the pronator teres and posteriorly by the imaginary line. Okay, and there are certain contents in it. Okay, there are certain contents in it. So let's see like what are the what forms the roof. So roof, the first one is the skin. Okay, the skin, and once you cut through the skin, you will be able to see the superficial fascia. Okay, the superficial fascia, and then the vein, the median cubital vein. Okay, by the way, did you find the answer? The median cubital vein. Did anybody find the answer? Why median cubital vein? is most commonly used for withdrawing blood? Can you please tell me loudly? Okay. Yes, it is a larger area. Any other reason? Yes. Hurts less. Okay, good. That's good. Why it hurts less? Okay. All right. Any other reason? Any other
Sir, it's
reason?
more stable. Sir, it's more stable and like stiff, kind of.
Good. It's more stable. How is it more stable?
Maybe it's more stiff.
No, it's not stiff. All the veins have the same characters, right? Okay. The median cubital vein is more commonly used for withdrawing blood. Okay, so for the reasons which you have said, okay, one of the things is it's easily accessible. Okay, less painful. Okay, why it is less painful? Because it is superficial. Okay, but there are many other veins which are also superficial. Here you can see there are cephalic vein, the basilic vein. These are also superficial veins. But usually we prefer this one because this vein, it goes between the fascia and it is stable. Okay, it is stabilized by the bicipital aponeurosis. Okay, what is this bicipital aponeurosis? From the biceps, you know, biceps tendon, right? The arm, they must have told you, right? Biceps muscle, biceps brachii. The biceps brachii, at its insertion, okay, at its insertion, see here you can see the biceps brachii. Okay, so at its insertion, it will be sending a, flat tendon, okay, a flat tendon towards the skin, and that's called as bicipital aponeurosis. Okay, so this bicipital aponeurosis forms like a platform, okay, which holds the median cubital vein in its place. Okay, suppose if you take the other veins, the other veins move, like the vein on the dorsum of the hand. Okay, you cannot catch hold of these veins because if you press on the medial side, it will move laterally. If you press on the lateral side, it will move medial. Whereas this vein, it's been held in its position because of the fascia and it's stable, and because there is the bicipital aponeurosis which is present. But one major drawback here is you should take care because deep to this bicipital aponeurosis, there are some important structures which go. There are some important nerves and arteries. Okay, so this bicipital aponeurosis also provides a safety zone. Okay, so that the person will not poke too hard. If they poke too hard, it is going to damage the nerve as well as the blood vessels there. Okay, so it also forms like a protective shield, the bicipital aponeurosis. Okay, so that's why we usually prefer the median cubital vein for withdrawing the blood. Okay, and the deep fascia, which is strengthened by the bicipital aponeurosis. So these are the structures which form the roof of the cubital fossa. The next one, the floor. The floor of the cubital fossa, it's formed by the brachialis muscle. Okay, it's formed by the brachialis muscle and the supinator. Okay, the supinator muscle. Okay, so these are the which forms the floor of the cubital fossa, brachialis and supinator. Now the contents. If you dissect through the cubital fossa, you will find a large amount of fat. Okay, so there is certain amount of fat which is present in this cubital fossa. Why there should be a fat? because there are many important structures in this area, in this region, okay, like the nerves, vessels, okay, and we do elbow flexion and extensions most of the time, okay, and during this action, these nerves and the blood vessels should not be injured. So that's why there is fat, okay, biceps tendon, okay, the tendon of biceps brachii and the bicipital aponeurosis. Okay, so this we have seen. Okay, the bicipital aponeurosis, which is an extension from the biceps tendon. It's an extension from the biceps tendon. Apart from it, there are certain arteries and nerves. The artery is the brachial artery. Okay, the brachial artery. And in the cubital fossa, the brachial artery divides into two branches. One laterally, which is the radial artery, and the other one medially, which is the ulnar artery. Okay, so lateral radial and medially the ulnar artery. The radial artery, once it comes out, it gives a branch which is the radial recurrent artery, and ulnar artery similarly gives off a recurrent branch, the ulnar recurrent artery. Okay, ulnar recurrent artery. Okay, so here you can see these recurrent arteries, they help in the anastomosis around the elbow joint. So thereby they keep the elbow joint vascular. The ligaments and other structures which are present in the elbow are kept vascular by these recurrent branches. Okay. Apart from this recurrent branch from the ulnar artery, there is another branch which is the common intraosseous artery. Okay, common intraosseous artery. Okay, so here you can see this is radial, this is ulnar, and here you can see the common intraosseous artery. Why it is called as intraosseous? Interosseous. Inter between osseous bone. You know there are two bones in the forearm, radius and ulna. Okay, these two bones, the radius and ulna, they are joined by a ligament which is the interosseous ligament. Okay, so there is a membrane which joins these two, which is the interosseous membrane. Okay, and this common interosseous artery, it comes out from the ulnar artery, and it again divides into anterior interosseous artery and a posterior interosseous artery. Okay, anterior interosseous artery and a posterior interosseous artery. Okay, so as the name indicates, the anterior interosseous artery will be found in the anterior part of the interosseous membrane, which connects the radius and ulna, and the posterior interosseous is found between radius and ulna on the posterior side. Okay, so these are the branches, the recurrent branch and the interosseous branch from the ulna and the recurrent branch from the radial artery. Okay, so here you can see the brachial artery. The brachial artery is dividing into radial as well as the ulnar artery. Okay, and here from the ulnar artery there is a common interosseous artery. Okay, all this will be shown in your dissection class. Okay, so when you come for the dissection, you need to look for all these features. Okay, you need to look for the brachial artery, radial and ulnar artery, the common interosseous artery. Okay, as well as the boundaries of the cubital fossa. Pronator teres, brachioradialis, the floor formed by the biceps. Okay, the bicipital aponeurosis. Okay, so those things you need to look for during your dissections. Okay, so here it's the dissection is being done more. Okay, and here you can see the brachial artery, which is dividing into ulnar and radial artery. And here you can see the common interosseous artery. The common interosseous artery then goes anterior to this interosseous membrane, which is the anterior interosseous artery. And there will be a division here which goes to the posterior part of the interosseous membrane. So that would be the posterior interosseous artery on the other side. okay, which you can't see it. Okay, on the other side. When you come for the dissection, we would be showing you this. Okay. Any doubts until now? Any doubts? All right. Now, some of the clinical importance, the brachial artery is used for recording the blood pressure. Okay. So, in your last module, that is the cardiovascular module. Okay, in physiology, there will be a practicals in which you may need to record the. You'll be asked to record the blood pressure. Anything? You will be asked to record the blood pressure. So how do they record the blood pressure? So that they will be tying a sphygmomanometer. This is an instrument. The sphygmomanometer, place it separately. Yeah, you. The sphygmomanometer. So this is an instrument which is used to record the blood pressure. Please, I don't want any talking. So they tie this sphygmomanometer, okay, and then they squeeze this bulb so that it squeezes the arm. Okay, so what happens? The pressure inside this rubber tubing will compress the brachial artery. Okay, so the blood is obstructed. Okay, then the pressure is slowly released. Okay, when they release the pressure, what happens? The artery just comes back once again and the blood starts flowing out. Okay, at this time they will keep the stethoscope over the brachial artery distal to the cuff, okay, and they will look for the sound. They will hear for the sounds. The first sound which you hear, that would be the systolic. The second sound, that is when it disappears, it's the diastolic. Okay, we will be discussing about this in detail in the cardiovascular module. The names of the sounds, it's called as Korotkov sounds. Okay, the physiology, they will be talking in detail about this. Okay, so one of the important thing here is you need to know the anatomy of the brachial artery. Okay, where will you keep the stethoscope? You cannot keep it anywhere. Okay, you need to know the anatomy where the brachial artery is present, and you need to keep the stethoscope over the brachial artery so that your blood pressure measurement is accurate. So where is the location of this brachial artery? So here you can see the radial artery, here the brachial artery. Okay, the brachial artery. It's close to this biceps tendon. Okay, it's close to the biceps tendon. Okay, in fact, it is medial to the tendon of biceps brachii. So you look for the biceps tendon in the cubital fossa and medial to it. Okay, so you can feel the brachial artery pulsations also in this region. Okay, you can feel the brachial artery pulsations in this region. So you need to keep the stethoscope exactly in this point to make your recordings accurate. All right. So this is regarding the brachial artery. Why is it important? Okay, the median cubital vein, we have already seen this, so I won't spend much time in it. Okay, so it joins the cephalic and the basilic vein. Okay, and is separated from the brachial artery by the bicipital aponeurosis. Okay, so that's why when you're giving injection, you need to be more careful that you should not poke too much. Okay, if you press too hard the needle might injure the brachial artery. Okay, it might injure the brachial artery and there is going to be a heavy bleed. Okay, so these are the reasons why the median cubital vein is preferred for withdrawing the blood. Okay, so the withdrawing the blood, it's called as venipuncture because it overlies the bicipital aponeurosis, which forms like a table. Okay, so over which you can press the needle and easily withdraw the blood. It's fixed by a perforator vein. Okay, perforator vein is a small vein which is present below and it holds the vein in its position, and it's not accompanied by any sizable cutaneous nerves. That's the reason that it is less painful. Okay, so there are cutaneous nerves, okay, but they are not too big. If the nerves are quite big, then the pain is going to be more. Okay, so it's not accompanied by any sizable cutaneous nerve. So these are the reasons why we prefer the medial cubital vein for withdrawing the blood. The next one is the cubital tunnel syndrome. This cubital tunnel syndrome, it's because it's not actually in the cubital fossa, it's slightly away from the cubital fossa. You can see this is the nerve which is coming on the medial side, and it gets entrapped below this medial epicondyle. As it comes below this medial epicondyle, it can get injured. So what nerve is this? What is this nerve which winds around the medial epicondyle? Ulnar nerve. Okay, it's the ulnar nerve. Okay, the ulnar nerve. So it can get squeezed in this region in the cubital tunnel syndrome. Okay, and can cause similar symptoms. Okay, so that's the cubital tunnel syndrome and can cause features of ulnar nerve paralysis. Okay, the ulnar nerve paralysis is a separate topic which will be dealt by Dr. Kumar. Now coming to the muscles of the forearm. Before we go into knowing the actual muscles, the osteology has already been finished, right, by Dr. Ansa, right? So just a recapitulation to know like what are the structures. You need to know these structures, okay, when you come for the osteology, because in your practical exams, we might give you bones and shade out certain parts and ask you what are these parts, okay, and what are the muscles which are originating or inserted into these parts, okay. All right, so here you can see the radius, the head of radius, the neck of radius, the radial tuberosity or the bicipital tuberosity. This is where the biceps tendon is getting attached. The interosseous border, okay, so by which this is the place where it gets the interosseous membrane, okay, is present and attaches the radius and the ulna together. Okay, the pronator tubercle, it's not shown here. Okay, so it will be present in this region. Okay, the styloid process. Okay, the styloid process in the lowermost teeth. So these are the structures in radius, and in the ulna, the olecranon process, the trochlear notch, the coronoid process, the radial notch. See, remember this is an ulna bone, but here you can see the radial notch. Okay, the radial notch of the ulna, because this is the place where the radial head is articulating. Okay, the interosseous border, the supinator crest, okay, the head and the styloid process. Okay, so these are the structures which you need to know, and these are the cutaneous innervations. The anterior aspect of the arm. Okay, so this is by the medial cutaneous nerve of forearm, and this is by the lateral cutaneous nerve of forearm, which is a branch from the musculocutaneous nerve. Okay, and here on the posterior side, it's by the posterior interosseous nerve. Okay, the posterior cutaneous nerve of forearm, the lateral cutaneous nerve of arm, and the medial cutaneous nerve of forearm. So these are the cutaneous innervations of the forearm. Okay. Now in the forearm, so these are the things which we have seen already: the subcutaneous veins, the cephalic vein, the basilic vein, and the median cubital vein. Okay, And here you can see the tendon of biceps, the brachial artery. Okay, and here you can see the ulnar nerve, and this one is the median nerve. Okay, and this is the radial nerve. Okay, the radial nerve on the lateral side. Okay, and the ulnar nerve on the medial side, and the median nerve approximately in the middle. Okay, the brachial artery, which later on divides into radial and ulnar artery. Okay, now before we go into these muscles, okay, so the muscles in the compartments in the forearm can be divided into compartments. Okay, the muscles in the anterior compartment, the lateral compartment, and posterior compartment. Okay, so this is for our reading to understand better. Okay, so the muscles in the anterior compartment of forearm, muscles in the posterior compartment of forearm, and the lateral compartment. Some books, they may combine both the lateral and the posterior together. They may say the entire part as the posterior part. Okay, the entire part as the posterior part. Now, these are all the muscles which are present in the anterior compartment. Okay, so these are all the muscles which are present in the anterior compartment. Now, how should I remember this one? So, now first, what I would do is I will just give you an idea of the muscles. Okay, I'm not going to go into the details of each muscles. Have you been told about the Ackland video? Yes. Okay, I would suggest you to go through the Ackland video. So you can type through the rakamhsc.com and the e-library. Okay, so once you go into the e-library one, you need to sign in using your university email ID. Okay, it won't work with your other Gmail. Okay, and go to the ebooks. Okay, ebooks, and you can type it here also. Look for Ackland. All right, see Ackland videos. Okay, you just click on it. So this is a series of videos which a person will be explaining in detail. Okay, so what I would ask you to do is, say for example, I'm taking one of these muscles here. Okay, say pronator teres. Okay, so I don't know what is this muscle. Okay, I'm just typing this muscle. Okay, it then takes on to the video. Okay, each video is not more than 5 minutes. It's just less than 5 minutes. Okay, and you can see a person who is describing about these muscles. Okay, so I suggest you can even download this in your mobile also. So he will be telling about the origin and insertions in detail. Okay, because if I go through each one of them, it will take more time and you cannot grasp it. Okay, I will tell the salient features now, the important parts of all these muscles. I'll tell the names of these muscles, the origin and insertion. You can look here. Also the locations. Make sure you know about the location. Look, he is also describing why it is called as pronate. Okay. He is also telling why it is called pronator, because when this muscle contracts, what happens? Pronation takes place. Right? So like this, he will be describing each of these muscles. Okay? Suppose if you want to see, say for example, I want to know like what is brachioradialis. Okay? He even describes about these muscles. Okay, brachioradialis. You can directly go to that brachioradialis. Okay, so it shows the brachioradialis. Okay, so example, bicipital aponeurosis. Okay, so here he shows about the bicipital aponeurosis. So that's the bicipital aponeurosis. Okay, so this is the biceps tendon. So from the biceps tendon, there is the bicipital aponeurosis. Okay, so this is the bicipital aponeurosis. So I suggest you to go through this video as many times as you want so that you can understand much better. All right. So make use of this video. Now what I will do is I will be telling you how to remember these muscles and what are the names of these muscles. So I said in the forearm, it can be divided into anterior compartment, lateral, and the posterior compartment. Now let's see what are the muscles in the anterior compartment of the forearm. The muscles in the anterior compartment of the forearm, they can also be called as flexor compartment. Okay, flexor compartment. Why? Because they help in flexion of the wrist, as well as some of them by the flexion of the fingers. Whereas the muscles on the posterior part, as well as on the lateral part, they help in extension. So they are called as extensor compartment. So anterior flexor, posterior extensor. Okay, flexor compartment and extensor compartment. Lateral is also included in the posterior compartment. Now, in the flexor compartment, the muscles can be divided into superficial and deep. Some books also include an intermediate layer. Like Snell's, they include an intermediate layer. The Skidmore, they do not include the intermediate layer. It's up to you, like whichever books you follow. Okay? So here you can see the superficial muscles. Most of the flexor compartment muscles originate from the medial epicondyle of the humerus. Okay, so from the medial epicondyle of the humerus. Okay, so they emerge from here, most of the muscles. Okay, so they originate from the medial epicondyle of the humerus. Okay, now the first muscle, the pronator teres. I already told you that the name, why is it being given? Okay, because they help in pronation and they are round in shape. The pronator teres. They originate from the medial epicondyle, okay, and they are inserted into halfway in the radius, in the middle of the radius, approximately in the halfway of the radius. And that's why with this muscle, when they contract, they help in pronation. Okay, because when it is attached to the radius, halfway in the radius, when it contracts, they help in pronation. So pronator teres. The next muscle, flexor carpi radialis. Okay, so what is this muscle? This is a flexor muscle, that is, they help in flexion. Flexion of what? The wrist. Okay, what are the bones present in the wrist called as? Carpal bones. Carpi. So flexor carpi. Okay, And where is it attached to? The radial bone, along the radial side. Okay, so it's called as flexor carpi radialis. So the next muscle to pronata teres, it's the flexor carpi radialis. Okay, flexor carpi radialis. Okay, the next muscle is palmaris longus. Okay, why it's called palmaris? Because this muscle, it goes into the palm. Okay, it goes to the palm of the hand. Okay, so that's why it's called as palmaris. And why it is called as longus? Whenever I say there is longus, there is something which has got a short tendon. Longus it's called because it has got a long tendon. Okay, so there is something which has got a short tendon. Only when both the muscles are there, we call it as palmaris longus. So it means that there is something which has got a short tendon almost in the same area, and that is called as palmaris brevis. Okay, palmaris brevis. We are not going to discuss about palmaris brevis now. Okay, that will be taught you in the hand. Yes. So palmaris longus has got a long tendon. Okay, and palmaris brevis has got a short tendon. Okay, but palmaris longus is a forearm muscle. Okay, it's a forearm muscle. The next one is flexor carpi ulnaris. So here you have seen flexor carpi radialis, which is present along the radial side. There is another flexor which flexes the wrist along the ulnar side, and that is the flexor carpi ulnaris. So these are the four superficial muscles: pronata teres, flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. Okay, the four superficial muscles. Now, in the intermediate part, there is another muscle, flexor digitorum superficialis. Okay, it is a flexor, so it helps in flexion. Flexion of what? The digits. Okay, they help in the flexion of digits. That's why it's called as digitorum. Okay, and it is superficial, so that's why it's called as superficialis. Flexor digitorum superficialis. Some books include this in the superficial group as well. Okay, so flexor digitorum superficialis. So whenever I say that is superficialis, there is something, a similar muscle which is D. What is that? Flexor digitorum profundus. This is quite deep and fleshy, more fleshy. Okay, so flexor digitorum superficialis and flexor digitorum profundus, which is slightly deep. All right. Then the thumb. The thumb is being given a different name. In Latin, it's called as pollex. Okay, pollex, Pollex. Okay, so there is a muscle which helps in the flexion of the thumb. Okay, so flexus, this is called as flexor. Flexor of what? The thumb. Thumb is called as pollex, so pollicis. Okay, and there is another muscle which also flexes the thumb, but this muscle has got a long tendon, so that's why this is called as flexor pollicis longus. Okay, flexor pollicis longus. Okay, flexor pollicis longus. The next muscle, there is another muscle which is called as pronator quadratus. Pronator because they help in pronation. Okay, quadratus. Quadratus because it's quadrilateral in shape. It's quadrilateral in shape. This is the only muscle which is not originating in the medial epicondyle. This muscle is present in the distal end from the radius to the ulna. Okay, so they are present between the radius and ulna, and when they contract, they help in pronation. Okay, so these are the muscles which are present in the anterior compartment. So in the superficial part, pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris. Intermediate, flexor digitorum superficialis. Okay, then next to it will be flexor digitorum profundus. Okay, flexor pollicis longus and pronator quadratus. Okay, it is difficult to remember these names. Okay, so I suggest you to go through that video again and again. Okay, see this video 2 or 3 times. Okay, when you see those muscles, you can understand it much better. And when you come for your practical class, we will once again revise. Okay, and when you see those muscles, you can confirm it. Okay, now all the muscles, anterior compartment muscles, they are supplied by the median nerve, except the flexor carpi ulnaris, the medial part of flexor digitorum profundus, these two muscles. These two muscles, since they are present on the medial side, they also receive blood supply, sorry, the nerve supply from ulnar. Okay, so now you know the importance of the median nerve. If the median nerve is injured, what will happen? Flexion is lost. The flexion of the wrists, okay, as well as the fingers, they become weak. Okay, so that's why the median nerve is also called as the laborer's nerve. Okay, laborer, they use mostly the forearm, okay, for working, right? So the median nerve is also called as the laborer's nerve. The arteries which are present in the anterior compartment, we have already seen that the radial artery and the ulnar artery. The ulnar artery divides into common intraosseous artery, which divides into anterior and posterior intraosseous arteries. Okay. Now let's go to the lateral compartment. In the lateral compartment, there are two muscles. One is brachioradialis. We have already seen this, forming the lateral boundary of cubital fossa. They originate from the lower part of the humerus, that is the arm, and that's why they are called as brachium. Okay, brachio, and they go and get attached towards the radius. Okay, brachio radialis. Okay, and there is another muscle, extensor carpi radialis longus. Quite a long name. Okay, how to remember? Extensor, extensor. It helps in extension. Extension of what? The carpi, the wrist. Okay, and it is present on the radial side. So it is called as radialis longus because it has got a long tendon. So when I say there is extensor carpi radialis longus, there is extensor carpi radialis brevis. So there is another muscle which is called as extensor carpi radialis brevis. The brevis will have a shorter tendon. Okay, if there is only one muscle like extensor carpi radialis, that's all. We will just stop at that. We will not say it's longus and brevis. But when there are two muscles which are getting originated from the same point or getting inserted in the same point, and one has got a long tendon, we call it as longus and brevis. Okay, so these are the two muscles which are present in the lateral compartment: brachioradialis, extensor carpi radialis longus. Okay, so the branches from the radial as well as the brachial arteries come here, and these muscles are supplied by the radial nerve. Okay, they are supplied by the radial nerve. Lastly, the posterior compartment. The posterior compartment, which is also called as the extensor compartment. Now, what are these muscles? What are the muscles which are present here? I told you extensor carpi radialis longus. So the brevis is present here. Extensor carpi radialis brevis. Okay, extensor carpi radialis brevis. Okay, so that is they help in the extension of the wrist and is present along the radial side. Okay, so extensor carpi radialis brevis. The longest is present in the lateral compartment, but some books say that both the longus and brevis are present in the posterior compartment. Okay, so your questions will not be like that, in which compartment it is present in. Your questions will be more of like an action. What action does it perform? What happens if the nerve supply is lost? Okay, it will be more applied. So when I say there is extensor carpi radialis, which is on the radial side, there is another extensor on the ulnar side. So which is extensor carpi ulnaris. Now here if you see it is just extensor carpi ulnaris. I have not included ulnaris longus and brevis. Why? Because there is only one muscle. Okay, so that's why extensor carpi, it helps in the extension of the carpus. Okay, and is present along the ulnar side. So extensor carpi ulnaris. Okay, so extensor carpi radialis, longus and brevis, extensor carpi ulnaris. They help in the extension of the wrist. Now, what about the fingers? The fingers. There is extensor digitorum. There is extensor digitorum, which helps in the extension of the fingers, like flexor digitorum. Okay, yes, for flexor there are two muscles, flexor digitorum superficialis and profundus. But for extensor there is only one extensor, extensor digitorum. Okay. However, the index finger and the little finger. Okay, the index finger and the little finger receive an extra tendon. They receive an extra muscle. Okay, which is called as extensor indicis and extensor digiti minima. Okay, the index finger, the finger which you point at. Okay, so that's the index finger and the little finger. Okay, they receive extra muscles, tendons from extra muscles apart from the extensor digitorum. And since this goes towards these specifically only to these fingers, they are given the name extensor digiti minimi and extensor indicis. Okay, extensor indicis. All right, I'll repeat it again. All right, then the thumb. Coming to the thumb has got an extension action, So there are two muscles which are responsible for the extension of the thumb, which is extensor pollicis longus and extensor pollicis brevis. Two muscles help in the extension of the thumb. Okay, so extensor pollicis longus and extensor pollicis brevis. And there are two muscles which help in the abduction of the thumb. So that's called as abductor pollicis longus. But the brevis I didn't include here because it is a muscle of the hand, not in the forearm. Okay, so abductor pollicis longus and abductor pollicis brevis. They help in the abduction of the thumb. Okay, so once again I will tell you the muscles in the posterior compartment. First, the wrist. In the wrist, there is one muscle along the medial side and two muscles on the lateral side. The muscle on the medial side is extensor carpi ulnaris. The muscles on the lateral side is extensor carpi radialis, longus and brevis. They help in the extension of the wrist. Now the digits. In the digits, extensor, digitorum. Okay, extensor, digitorum. But the index finger and the little finger, there is the extra tendons. Extensor indices and extensor digiti minima. Okay, extensor indices is to the index finger and extensor digiti minimi is to the little finger. Okay, extensor indices and extensor digiti minima. Now coming to the thumb has got an extensor pollicis longus and brevis, and an abductor, which is abductor pollicis longus. The brevis is also there, it also helps in abduction, but it's not a forearm muscle, so I have not included it here. Okay? All right? Apart from this, there are two deep muscles. One is the supinator and anconeus. Okay, anconeus. They are quite deep muscles. Okay, so anconeus is very superficial. Okay, and supinator is very deep. They help in supinating action. But do you know like which is the strongest muscle which helps in supinator? In supination? Which muscles help in supination? Pronation you already know. Pronator teres and pronator quadratus. Which one? Biceps. Okay, the biceps as well as the brachioradialis. Okay, so they also help in supination. Okay, the supinator is only a weak supinator. They help in weak supination. All these muscles are supplied by the radial nerve. Okay, and the posterior compartment is by both the anterior as well as the posterior interosseous artery. Okay, so that's why when the radial nerve is injured, what will happen? Wrist drop. Okay, wrist drop. Why there is wrist drop? Because the persons cannot extend their wrist. Okay, they cannot extend their wrist. Okay, so that's why on paralysis of radial nerve, it leads on to wrist drop. Okay, now once again, I will just tell you both the compartments, muscles in the anterior as well as the posterior compartment. The anterior compartment, it's the flexor group. Okay, the flexor muscles. Okay, so that is the first muscle which helps in pronation, which is the pronator teres. Okay, the next muscle help in flexion of the wrist, which is flexor carpi radialis, and there is flexor carpi ulnaris on the medial side, and there is one muscle which goes to the palm, which is palmaris longus. Okay, now next to it, to the digits. To the digits, there are two muscles, flexor digitorum superficialis and flexor digitorum profundus. Okay, digits. When I say the digits, it's only the four fingers, not the thumb. Okay, the index, middle ring, and the little. Okay, flexor digitorum superficialis and flexor digitorum profundus. Now to the thumb, flexor pollicis longus. There is another muscle which is the pronator quadratus. Okay, amongst all these muscle, all the muscles originate from the medial epicondyle except for the pronator quadratus. And all these muscles are supplied by the median nerve except flexor carpi ulnaris and the medial portion of the flexor digitorum profundus. The lateral compartment, it is the brachioradialis and the extensor carpi radialis longus. Okay, the brachioradialis also helps in flexion. Okay, in the mid prone position. Okay, they help in flexion. Okay, the brachioradialis flexion of the elbow at the elbow joint. Okay, as well as there is extensor carpi radialis longus. The posterior compartment, the extensor of the wrists. There is two on the lateral side. That is the extensor carpi radialis longus and brevis. One on the medial side, which is extensor carpi ulnaris. To the digits, there is extensor digitorum, but the index and the little finger, there is a extra tendons by extensor indicis and extensor digiti minimi. Okay. Then the thumb has got its own extensors, extensor pollicis, longus and brevis, and abductor. Okay, extensor is, this is flexion, this is extension. Okay, abduction, adduction. Okay, sorry, adduction, abduction. Okay, so abductor, pollicis, longus. Okay, abductor, pollicis, longus, and brevis, but brevis I have not included because it's not a forearm muscle. Okay, abductor, pollicis, longus. Okay, all these muscles in the extensor compartment, they are supplied by the radial nerve. Okay, and that's why in radial nerve paralysis, extension will be weak. Okay, and it's called as wrist drop. Okay, wrist drop. Okay, now you can, arm is finished, right? Now, in which fracture the radial nerve can be involved? In which fracture the radial nerve can be involved? In which fracture? Any idea? In the arm. A fracture of the arm, at which point can damage the radial nerve? Shaft of the humerus. Fracture shaft of the humerus at the level of the radial groove or the spiral groove. Okay, so you know that the radial nerve winds around the spiral groove, the shaft of the humerus. So if there is a fracture of the humerus at the level of the radial groove or the spiral groove, the radial nerve can be involved, following which the patient can have wrist drop. Okay, where the extension of the wrist will be weak. Okay, so with this in mind, you try to solve some clinical scenarios. In your Snell's, at the end of the Snell's, there are a large number of multiple choice questions which has been given. Try to work out those. Okay, those will be of really high standard, but I suggest you to work it up. Okay, understand the question and then try to reason out the answer. Okay, that itself is enough for you. All right. Okay, now coming to the next part, the anatomical snuff box. Okay, snuff box. If you see, if you extend the thumb, here you can see an hollow depression. Okay, a hollow depression if you extend the thumb. Okay, and you can feel the two tendons between it. There are two tendons. So here you can see this is extensor pollicis longus on the medial side and abductor pollicis longus and extensor pollicis brevis on the lateral side. So in between this there is a gap. So that gap is called as anatomical snuff box because it resembles like a box. Okay, snuff box. Okay, in the olden days, people used to have tobacco in a box, okay, and then sniff it. Okay, so anatomical snuff box. Why this is important? Because there is an important artery which comes here, the radial artery. Okay, and also deep inside this, there is scaphoid bone. You can feel for the scaphoid bone. Scaphoid is a carpal bone. Okay, and scaphoid fractures. What happens? Scaphoid fracture is very important because the radial artery goes and supplies the scaphoid at a critical point. So, in case of scaphoid fracture, the vascular supply to the scaphoid can be cut. Okay, the vascular supply to the scaphoid bone can be cut, and when it is cut, it can lead on to avascular necrosis of scaphoid. What is avascular necrosis? Vascular, you know, it has got blood supply. Avascular, no blood supply. When there is no supply, blood supply to a bone, what will happen? It will die. So avascular necrosis, okay, of scaphoid. Okay, so that's quite common. Okay, so especially on a person who falls on an outstretched hand. Okay, if a person trips and then he falls, so what is the first point of injury? So he will keep the wrist over the floor. Okay, when he keeps the wrist over the floor, the impact can injure the wrist. Okay, and when it gets when it hits the wrist, the scaphoid can be fractured. And when the scaphoid is fractured, it's quite difficult to heal. If the artery is also damaged, okay, it can be quite difficult for it to heal and can lead on to a chronic pain in the wrist. Okay, so that's why this is important. The anatomical snuff box. Okay, so during the surgery, they will be looking for if there is any cut to the injury to the blood supply of the scaphoid in this region. Okay, De Quervain's tenosynovitis. If you see the extensor tendons, the extensors have got a more number of tendons. Okay, and here if you see between the extensor pollicis brevis and abductor pollicis longus. Okay, so they both are enclosed in a same sheath. Okay, and if there is any inflammation in this region, it can lead on to a pain in the thumb. Okay, so especially when they write something, it will be very difficult. Okay, so this is called as De Quervain's tenosynovitis. Okay, which involves abductor pollicis longus and extensor pollicis brevis. Compartmental syndrome. What is compartmental syndrome? So as I said, there are said before, there is an anterior compartment, posterior compartment, lateral compartment. Okay, the anterior compartment has got a superficial and deep. Okay, so what happens? Why this is important? Because suppose if a person has sustained a fracture, say, and during a sports, okay, or sometimes a blunt injury to the forearm. So here in this person, you can see there is no exterior wounds. On the external part, there is no, the skin appears to be intact. Okay, but what happened is inside there could be a bone fracture, or what happened is there could be an arterial damage. Okay, the arteries or veins, they could have ripped off. And what happens when there is damage to this arteries or veins, the blood gets collected in this compartment. And what happens when the blood gets collected in this compartment? It leads on to swelling, and when it leads on to swelling, it leads to compression of the other arteries and the nerves. Okay, the other arteries and nerves. Okay, so this is a very important condition which you need to find out, especially in a person who has received a blunt injury. When the skin is intact and there is swelling, okay, you need to suspect if there is compartmental syndrome. How to find out if there is a compartmental syndrome? Look for the pulse distal to it. Okay, you can look for the pulse distal to it. If you are able to feel the pulsations, okay, it's fine. There are no problem. There's no problem. And for the sensations as well as the movement. Okay, if the person is able to move the fingers, and if you are able to feel for the distal pulses, the radial and the ulnar, okay, so then it is fine. Okay, any other point to how to check about the blood vessel blood vascularity? You can do what is called as capillary refill testing. Okay, you can see the finger, the nail. The nail is pink. Okay, you press the nail for 2 seconds and then release it. Okay, immediately it should fill up. Okay, the pinkness should come back on once again. This is called as capillary refill time, CRT. Okay, capillary refill time. If the capillary refilling takes more than 5 seconds, okay, more than 5 seconds, then you can suspect that there is a compartmental syndrome. Okay, so this is very important and it has to be diagnosed immediately because otherwise it can lead on to further damage. And what is the immediate surgery? You need to make an incision. That's it. You need to cut open the fascia, the deep, because it's because of the deep fascia. The deep fascia is quite tight and sleeves around the forearm, and there is collection of blood, okay, which keeps on building up. So what you need to do is you need to make an incision on the deep fascia. So you need to remove the skin, superficial fascia, and make a deep cut in the deep fascia so that the pressure is released. Okay, and further damage to the nerve is avoided. Okay, so that is called as fasciotomy. 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 Okay, so compartmental syndrome, so in which a particular compartment can get compressed, leading on to damage to the surrounding structures. Okay, and what happens if it's been ignored? It can lead on to Volkmann's ischemic contracture. Okay, so if there is a chronic, if this compartmental syndrome is not corrected immediately, okay, the blood supply to these muscles can be lost. And what happens? The muscles can go atrophy. Okay, ischemic atrophy. So this is called as, and they can go on to permanent contracture. This is called as Volkmann's ischemic contraction. This is important even in when you apply plaster of Paris. When you apply a bandage or a forearm fracture, after applying the plaster of Paris, you need to check out whether the person is able to move the fingers and the capillary refill time is normal. Okay, so if the capillary refill time is normal, it's good. If it is not there, you need to open up the plaster of Paris and then make it a bit loose. Because what happens sometimes after the bandage, there will be swelling. Okay, there will be swelling of the forearm. Okay, and it will compress by the plaster of Paris. So the person will be having a swelling which will be inside the bandage and nobody can see it. So you need to check out by looking at the nail. Okay, the nail you need to just see if the capillary refill time is normal. Okay, then that's not an issue. Okay, if not, open the plaster of Paris and reapply it again. Okay. The next one is Colles fracture. This is also fall on the outstretched hand. Okay, if a person trips, okay, falls on outstretched and the wrist gets impacted. This is more common, especially in females after the age of menopause, because what happens after menopause? Osteoporosis. Okay, because there is depleted calcium, especially in females after menopause. Why after menopause? because of the hormones, the estrogen hormones. Okay, so they come down and it regulates the calcium. Okay, so the calcium depletion occurs. Okay, and if there is an osteoporosis in a person who walks and then trips, okay, fall on the outstretched hand, it can lead on to fracture. Okay, so here you can see the fracture of the radius, the distal end of the radius, okay, and it's been pushed up. Okay, so it resembles like a dinner fork. So this is called as a dinner fork deformity. Okay, a dinner fork deformity. Okay, which is called, in which there is a distal end of fracture, distal end of radius. Okay, and this fracture is called as Colles fracture. Okay, Colles fracture. The Smith's fracture, it's a bit rare. Okay, this is because usually when a person falls, he falls with the wrist, not with the dorsum of the hand. Okay, it's opposite to that of Colles fracture. Okay, so here the distal end of radius is once again broken, but here the broken part is towards the anterior aspect. Okay, it's towards the anterior aspect. Okay, so this is Smith's fracture. The Monteggia fracture and Galeazzi fractures. So in the Monteggia fracture, the ulna is fractured. Proximal ulnar is fractured. In Galeazzi fracture, there is the radius and ulna, they get moved away. Okay, as well as there is a radial fracture. Okay, as well as there is a radius fracture. So Monteggia fracture and Galeazzi fractures. Okay. Now we will not ask you the more of the names like Monteggia fracture, in Monteggia fracture which is fractured, Galeazzi fracture which is fractured, because those things you will be learning in your clinics as well. Okay, but what we would ask is what happens. See here in Monteggia fracture, the proximal ulnar bone is pulled up. So which vascular structure or which nerves or which muscles are attached? Okay. So which muscles are affected? Which artery is affected? Which nerve is more commonly affected in a Monteggia fracture? Okay. So like that we would ask you. Okay. In Colles fracture, you can see the distal segment is moved up. Okay. The proximal segment here, the fractured part, it's present more towards the wrist side. So which nerve is involved here? Any idea? The median nerve. So what you need to do is any person who comes with the fracture, you need to do the test for median, radial, and ulnar nerves and see if they are intact, because hands are very important. Okay, in humans. Okay, so that's why injury to the hand should never be neglected. Okay, so any injury to the upper limb, you need to check for the integrity of the nerves as well as the vascular supply. Okay, you need to check for each tendon. Okay, the each of this whatever the tendons which we have taught. Okay, like pronator teres, flexa carpi radialis, longus, brevis, extensors. Okay, each tendons you need to look for and look if there is any trouble. Okay, if there is any trouble, you need to do appropriate treatment for it. Okay, any doubts? Yes.
Sir, what do we call that test in which you press the nail and see how much time it takes for the blood
Capillary refill time. It's called as capillary refill time.
capillary refill time? Okay, thank
Yes.
you.
Yes. I can't hear you. Can you just come closer after the class? Or after the class, you can come closer.